Good morning. We were just saying that there's actually a bigger turnout than we had anticipated for Tuesday morning. For those of you who have flights, this probably will not go the entire time, though we welcome any and all questions and encourage questions from you at the end. My name is Shelley Iverson. I'm actually an assistant professor at UNMC in Omaha. I do a lot with medical student education. I'm actually an intensivist as well. Dr. Lubinsky is the interim chair, and he's the residency program director in Chicago. So he is wearing two very busy hats right now, especially during applicant season. And Dr. Doyle is exceedingly busy. She is the director of the ASA in California. She's actually private practice, anesthesia and intensivist as well, and she is the chair of her department. None of us have any relevant conflicts of interest or disclosures. So to jump right in, we're going to talk about the use of regional anesthetics in ICU patient populations. And just a little background about why we care about this, or we should care about this, is that pain is a very common complaint in the ICU patient population. And though most people think that pain is nothing more than a subjective score and it's now a fifth vital sign that we're all graded upon, it actually has long-standing and detrimental long-term implications and consequences. The systemic opiates and other mood-altering medications that we use to help mitigate pain actually have a lot of systemic effects that, especially in the ICU patient population, you don't really want. Encephalopathy and delirium, especially in our geriatric populations, is very common, and that too has long-standing morbidity and mortality consequences. Certainly hypotension, respiratory depression, the cardiovascular things that we as intensivists worry about, and then constipation and ileus, also another problem. So a couple learning objectives. We want to recognize and talk about the risk of performing anesthetics regionally in the ICU patient population. We want to distinguish and identify patients who may benefit from regional techniques, and we want to actually talk about employing this new knowledge to potentially advocate for your patients. And with that, I'm going to turn it over to Dr. Lubinsky.
Good morning, everybody. So aside from the continuous pain felt by ICU patients, there's a lot of other things occurring. They're frequently getting turned, suctioned, poked, prodded, and there can be a lot of additional discomfort that occurs in this critically ill population. And let's not even get started on things like dressing changes, bedside procedures. There's a lot of things that are going on 24/7 in the ICU that can lead to patient discomfort. Additionally, their critical illness leads to different derangements of their physiology through shock, inflammation, organ failure, and that affects everything we're doing. Because this in turn alters drug kinetics, some of the feedback loops that occur in the body, and they can lead to complications with anesthesia and our medications. But by knowing these changes that are occurring, you can tailor your approach and provide safe care to these patients, which includes a regional anesthetic. So even though these patients pose a unique challenge, that doesn't mean they deserve substandard care. I'm not pushing for a one-size-fits-all approach, but you have to take care to choose the right regional technique for the right patient and the right regional provider. If you have someone that this is their first time doing a block, this might not be the right patient for them. But when you take all these things into consideration, really the benefits of providing regional anesthesia starts to outweigh the risks. And you can provide analgesia without having some of the systemic effects of opioid medications and sedatives, which can lead to things like hemodynamic changes, changes in neurological outcomes, and can also help reduce your sedation needs, which can lead to less time in the ICU. All these things together, in addition to decreasing time in the ICU, lead to things like earlier mobilization and even decreased length of hospital stay. So epidurals have long been the gold standard when we talk about regional neuraxial techniques. And while we all know that when you put an epidural, patients get hypotension, we also know how to fix it. There's studies looking at epidural infusions, and they've not only shown excellent pain control, but reductions in pulmonary complications, reductions in thromboembolic events, decreased rates of ileus because you're able to provide less systemic opioids, improved pain scores, better length of stay, and some of the epidural studies actually show a decreased mortality rate at 30 days. So these patients with poor pain control can have pulmonary complications secondary to atelectasis, and a lot of times they get slammed with opioid medications, which may help with the pain aspect, but lead to respiratory depression on their own. So by providing regional and neuraxial techniques, you can improve pulmonary function, reduce some of the pulmonary complications, and this is an effect that's been most pronounced in some of the thoracic surgery patients or patients with chest wall trauma. There's also the added benefit of prevention of sensitization. So patients getting thoracotomy, there's the post-thoracotomy pain syndrome that can occur, and by getting neuraxial or getting a regional technique to kind of numb up those nerves ahead of time, you decrease that chance of wind up and having some of these long-term pain syndromes. So as I said, some of these epidurals can cause hypotension. We've all covered labor and delivery, put in an epidural, everything went fine, next blood pressure is a lot lower than you'd like to see, and then you're reaching for the phenylephrine. It's also the reason that a lot of surgeons and anesthesiologists shy away from placing epidurals in patients. But you have to remember that an epidural isn't your only option. This isn't even a complete list of the blocks we can do, but it's part of our whole armamentarium. As I mentioned, this is not a one-size-fits-all approach. You have to pick the right block for the right patient for the right indication. A patient getting a thoracotomy would greatly benefit from a thoracic epidural, but we have other blocks like erector spinae plane blocks, paravertebral blocks that can provide excellent pain control while decreasing some of the more systemic effects that you even see with neuraxial anesthesia. In terms of research, the research on peripheral regional anesthetics hasn't been as robust as some of the other parts of anesthesiology. But times have started to change. We're getting a lot more individual case reports and case series on different regional anesthetics. And Admiral et al. Did a 10-year review looking at the body of evidence when it comes to peripheral regional anesthetics. They found considerable evidence supporting regional anesthetics for a variety of indications, and they looked through different surgical procedures and what benefits there were with specific regional blocks for specific procedures. And this literature review didn't focus on the critically ill, but this study can prove as a proof of concept. And the critically ill have these other processes we need to worry about, but as long as you're aware of those processes and make adjustments and make choices accordingly, you can still provide safe and effective care for these patients. There are studies looking at things like local anesthetic dosing. So in varying states of organ dysfunction, what dose reductions you need to do. We'll talk about hematologic effects, blood pressure effects. But you also have to keep in mind things like, as you have a shock state, you can have change in the free fraction of local anesthetic, which can lead to potential downstream sequelae that you don't want. But knowing those things supports your ability to use studies like this and studies that are out there to kind of extrapolate into the critically ill population. So a lot of protocols using regional anesthetics have shown significant improvement in patient outcomes. Part of our jobs as anesthesiologists is to educate our colleagues. That surgeon that says, no, this patient can't get an epidural, so we're not doing any regional. They don't know about that list of blocks that we can do. There's new blocks kind of coming out every so often that you might not even have heard of yet, or I might not even have heard of yet. But that's part of what we're doing. We're trying to advance this field so we can get more tailored care for our patients. Can't even count the number of times a surgeon has said that they don't want a thoracic epidural because they think it's going to impair the patient's ability to get up and walk. Studies have actually shown that having thoracic epidurals, having increased pain control, leads to earlier mobilization of these patients. And that earlier ambulation leads to better outcomes and better functionality on discharge. And through these enhanced recovery protocols, patients have that earlier mobilization. They're better able to engage with physical therapy. I mean, we have patients getting their joints that are going up and down the stairs hours later. And this shortens their length of stay. This shortens their time in the hospital. So these ERAS protocols are leading to more functional independence at discharge. For the critically ill, improving pain and reducing systemic medications can literally be a matter of life and death. The stay in the ICU is really the only beginning of their battle. Many of these patients require re-engagement with the ICU team after they've been stepped down the floor. A lot of them get readmitted due to the sequelae of their diseases. But neuraxial and regional techniques have shown to improve their outcomes. As an added bonus for anyone that's involved in administration, there's also improvements in patient satisfaction scores. But gone are the days where mortality is really the only measure. We have to really look at the global patient and tailor that and think about that when we're planning on our best path forward. There's subsets of patients that have particular benefits, and that's really a whole talk unto itself, but I'm going to provide a couple examples. Patients with traumatic rib fractures often have difficulty weaning from the ventilator due to pain. And they're inadequate analgesia, and you're having this fine balance between giving them opioids and trying to get them off the ventilator and having respiratory depression. And while thoracic epidural may be great for these patients for pain control, it's not always feasible for a variety of factors. So many hospitals have protocolized things like the erector spinae blocks or paravertebral blocks because they provide excellent analgesia and help liberate patients from the ventilator, but have a lower risk profile. They're blocks that can be done with ultrasound. They're even like the ESP, you have a backstop of a bone, so the chance of getting into some of the surrounding structure and causing damage is minimized. In patients for a tracheostomy or have post-tracheostomy pain, a combination of a superficial cervical plexus block and a transtracheal block has been shown to provide excellent analgesia. And you can then decrease your systemic opiates, decrease your amount of sedatives, and get them off the ventilator earlier and get them breathing on their own. And for patients requiring frequent dressing changes, regional anesthetics offer an alternative to heavy sedation at the bedside or having to return to the OR for dressing changes. A couple years ago when I was at Georgetown, we had a patient in the ICU that had LOS or flap because they had a chronic empyema. And this patient needed dressing changes every other day. At first, they were going to the OR, getting general anesthesia for these dressing changes, until my former chief resident, who was the head of regional at Georgetown at the time, talked about doing an erector spinae catheter to help assist with these dressing changes. So he was able to place that erector spinae catheter, and we were able to actually supplement the patient's analgesia to the point where we were able to do these dressing changes awake at the bedside. And so there's also further studies that talk about LOS or flaps and doing bedside dressing changes with using ultrasound-guided dorsal scapular nerve blocks as well as long thoracic nerve blocks and their ability to provide adequate analgesia for these types of procedures. But again, in the absence of these blocks, this patient would have to go to the OR every other day and receive either heavy sedation or general anesthesia to further advance their care. So with the advent of ultrasound, things have really changed. A lot of our earlier techniques for regional blocks were all landmark-based, but now with the availability and the use of ultrasound, we've really changed our approach to these blocks and made them much safer. Ultrasound-guided regional anesthesia has really become the standard of care, and the use of ultrasound can improve efficacy of the blocks by seeing where your local is actually spreading, can minimize complications like bleeding or getting into surrounding structures. And it's also beneficial in some of our patients with distorted anatomy. I've had edematous patients where you put the ultrasound probe there and you just see that there's no longer those fascial planes you're targeting. So that may kind of tailor your approach, and maybe you have to do a different block or abandon that block entirely because what you're doing is not going to provide the benefit you think. So before we pass it off, just to summarize, regional anesthesia provides opioid-sparing analgesia. And while our opioids are fantastic medications, we all know that they do have downsides. By using regional anesthesia instead of some of these systemic medications and sedatives, we can improve some of the pulmonary diminish some of the pulmonary complications, improve pulmonary mechanics, lead to earlier mobilization. We have improved ICU outcomes. But you have to remember that when you're talking about regional anesthesia in the critically ill, it requires careful patient selection and looking at people's expertise. We want to make sure we pair the right patient with the right block and the right provider who is aware of all these changes that can occur to a patient's physiology when they're critically ill so we can provide safe care. And use of regional anesthetics in an ERAS protocol or as a multimodal approach in the critically ill does lead to positive outcomes. Dr. Doyle?
Good morning. It's sometimes hard to be the con side of an argument. We planned this way. So I'm Christine Doyle. I'm in private practice. And so the concept of calling for a pain consult is very different for us. And what I really like to talk to is less regional anesthetics are bad, because I don't think any of us would agree with that statement. But why should we not do them? There are reasons to not do them. Now let me see if I can figure out the right clicker thing. Okay, so within the ICU, you're going to really see two major issues that are going to limit your ability to use regional techniques. One's going to be technical. Can you physically do the block? Are there other issues that are going to be confounding? And the other thing has to do with metabolic changes that are pervasive in all of our ICU patients. And although certainly this includes epidurals, we're really talking about the other kinds of blocks, the ESPs, the adductors, pick a block for a variety of reasons. So we're going to start with what's mostly technical, figuring out my thing. So the technical challenges really fall into three big categories. I can't assess the patient for complications because they're sedated, because something else is going on. I can't identify a paresthesia, again, because they may be sedated, because they may not be able to cooperate with me because they're confused or delirious, and because I don't necessarily have help that can help me elicit things. And the last thing is the inability to get the patient in a position to do a block. So this may actually entail a trip to the operating room to do a big dressing change or something, and then put the block in where you have help that can get you through that. So we'll talk a little bit about all of those. How many here know about the 4 H's? Have you seen it before this? Yeah. So all of these patients are going to have all of these at some point in their ICU course or their immediate peri-op course. They're going to have a period of hypotension. They're going to be cold. They're going to be dry. And they're going to be hypoxic at some point. May not be for very long, but it all does add up. And you can have troubles figuring out if they have a baseline injury versus something related to your block. And so you have to really figure this out and figure out how to separate an actual nerve injury, whether it's from a block or from trauma, from the wasting and weakness associated with critical illness. Now, critical illness polyneuropathy is a whole other thing. That's going to confound things. And it's difficult for most people in most ICUs to make the distinction between what's I'm just weak because I haven't eaten and I haven't been able to get up and move versus I actually have an underlying nerve injury, whether or not we add a regional technique to it. So, how many of your nursing staff in the ICU actually know what a paresthesia is? Most of them don't. They know what the word is. They know what the word means, technically, in the book, but they don't actually understand what it means in the context of a patient. And they don't see blocks being placed very often. They don't take care of them that often. And so if you're in Graham's ICU and you do this a lot, they know what they're talking about. But if you're in the average ICU, especially my clinical community hospital sort of thing, it's going to be a real problem. The other issue is that patients can't communicate. They're sedated, they're intubated, maybe they can write, maybe they can't. Maybe their family is there and can interpret their body language for you, but you don't always know what's going on. And that's important because if the patient is having pain, despite the block, you may not know that and you may not be able to deal with, for example, compartment syndrome. And your non-anesthesia staff really don't understand the importance of a lot of these different things unless they're in a major trauma center that's used to looking for compartment syndrome. So we'll talk a bit about double crush because it's something that I think there's a lot of double insult issues both in trauma and in ICU that we don't always think about consciously. You have the insult of the initial trauma event and then you have the insult of the surgical event. You have the insult of a crush injury, and then you have a second crush injury. And in particular for us in the operating room and ICU situation, the pre-existing peripheral neuropathy, which is many of our patients, if not most, can then have a secondary or double injury And that can be the patient who's diabetic, who has peripheral neuropathy, who goes to the OR and gets total knee and now has a secondary crush injury from the tourniquet. And now they've got a lot of problems with their leg. So it really depends on where you're going. That's a common one. But the other one also is that they may have two separate injuries. They might have an injury in the upper arm and the lower arm, and that's going to cause problems. It's often talked about in terms of things like carpal tunnel syndrome, that you've got two injuries and that's what's making it worse. Generalized edema is common in our ICU patients. That can cause in and of itself an injury just because of the swelling, not up to the level of a compartment syndrome. They may have pre-existing cervical or lumbar radiculopathy. They may have sciatica. They may have anything else, and then any other injury on top of it will make it worse. So you have to have a high index of suspicion. You have to train your nurses to be looking for this. You have to really evaluate patients closely. And you also have to make sure that your surgeons and your intensivists don't ignore this and think it's no big deal. I think all of us have had some disaster at our facility where somebody ignored the signs and symptoms of a compartment syndrome, at least initially. So then we have positioning issues. Can you sit the patient up to do an ESP block? Now, maybe if the patient's prone, it might be easier to do the ESP block. They're already in the right position. But I've never done one in that position. I don't know that I want to start learning how to do that in a critically ill ICU patient who requires proning. Are there fractures? Can you safely move this patient because their leg hurts because it's broken, but can you get them in a position where you can safely do a block? If you have your OR staff who are used to helping hold patients for a block, an epidural, anything else, know how to assist you on that, it's not so bad. Do you need to bring your OR staff over to the ICU to teach them how to do this and make it safe? And is it safe to sit that patient up who has a femoral line, who's intubated, who has all these other things attached to them? So the logistics can be quite difficult. Not impossible, but quite difficult. And I will say that, femoral lines are going to generally be more of a problem than subclavian or IJs, because I think we're more likely to need either thoracic or leg blocks than upper arm blocks. The upper arm blocks, though, are still easier to do and work around that. And so you do need to consider that. Maybe you need to change where the line is so you can get the block in. It depends. Okay? So let's talk about metabolic stuff. These are actually, in some ways, the bigger things and the harder to diagnose things. Coags, pharmacokinetics changes, metabolism in general. So, now, I'm not an ASRA member. I strongly recommend the ASRA Coags app. They just re-released it. This is the new splash. I will say that if you are not an ASRA member, there is now a $6.99 charge, so I'm upfront about it. I consider it money well spent. My surgeons consider it money well spent. They have all glommed onto this once I trained them to look for it, and have decided it's great because it stops the arguments about have they stopped their anticoagulation or can they get a block or especially an epidural spinal. I do strongly recommend that you look at the entire coag profile, not just a single PT or INR, and depending on your facility, they may report it one way or the other. Look at everything. Look at the trend. Was there INR 1.1 today and it's 1.5 yesterday? We're going the right direction. Maybe it's going the other direction. Consider if you need to get D-dimers and Rotem or TAG, whatever you have in your facility. It can give you some really early clues about, yeah, I could do a single shot safely, but I can't put a catheter in, or vice versa. Also consider the issue of mechanical versus chemical DVT prophylaxis. So I'm old enough that I remember when the chest journal and the ICU and pulmonary folks all recommended everybody get anticoagulation. It's like, but. And the surgeons were really pissed off because they were having more post-op bleeding. And so finding where you are in that process at your facility with this patient, are they on chemical prophylaxis? Is that enough to get your coags out of whack? And I don't know about your facility, but at my facility, that's one of our quality metrics. Do they get their chemical prophylaxis? So think about that, okay? Now, this is a really nice summary slide from the European Society of Anesthesiology and Intensive Care looking at regional anesthesia and antithrombotic drugs, meaning the chemical prophylaxis. And I emphasize what's down at the bottom right. The key message is what things make a difference. If they're on an antithrombotic and how much. What's their renal function? How impaired is their drug elimination, renal function being a part of that? Do you have a reversal drug you could give? Can you give them the Pradaxaperson, dabigatran, or do you give them vitamin K or something like that? And then if you're doing a procedure, do you have a bloody tap? Ultrasound doesn't make a difference. Drug combinations don't make a difference. Bleeding risk scores don't make a difference. I must admit I was a little surprised about some of that. But you just need to, again, have a systematic process that you're going to go through. Was anybody else at the Severing House? This is the type 2. So in terms of pharmacokinetics, I always joke, invoke the third space, always. Whether or not it really exists is different. You know, fluid balance is going to be out of whack. They may be really dry. They may be really overloaded. You don't know where they're going to be. You don't know how much of that fluid is intravascular versus in the subcutaneous and third space tissues. And so you need to make sure that you understand what might happen to your drug when you deposit it wherever you're going to deposit it for whichever block you think. Expect that you're going to have some pharmacokinetic variation. Drug may last longer than you expect. Drug may get metabolized faster than you expect, more likely to be lasting longer than you expect. You know, we have no way to measure absorption or distribution or clearance at the bedside. We measure substitutes. We measure things like creatinine level or creatinine clearance if we're being really aggressive. The amount of edema that you see, the patient looks like they're, you know, Pillsbury Doughboy, that doesn't necessarily tell you how their pharmacokinetics may have changed. So you need to look at that. So you have to make, this is something that you can't just read a book or read some table. You have to look at that patient. You have to make a decision and decide if you think they're going to need a dose adjustment. And then once you've made that decision, you have to decide how much of a dose adjustment. There's no real references in the literature that tell you anything about that. It's all, unfortunately, clinical judgment at the bedside. The other thing to consider is which drugs you're picking. If you're using esters or amides. The esters, remember, are degraded by pseudocholinesterase, and the amides are degraded in the liver. If the patient has decrease in their liver metabolism, commonly seen in critical care patients, the active drug may remain at higher levels for longer times. So that may increase your risk for last, and it may be a prolonged window for last compared to normal. The renal metabolism is, of course, also often decreased. We have many patients that are on CVVH or other things to replace that. So even if the liver's working okay, you may not be excreting the metabolites from the various drugs. And it's not clear if they're going to be dialyzed, if the patient's getting dialysis. And it's not clear how many of those metabolites may contribute to the risk of not just LAST, but other syndromes, because nobody really looks at it. Now, we see changes in the biochemical pathways, and oxidation or oxidative stress, okay, that's the fruit that's rotting in your refrigerator. It happens within the human bodies, and we don't think about that very much. I mean, we talk about antioxidants and all that sort of stuff, but we don't think about what the real implications are. Oxidation can damage all sorts of different kinds of cells. Hyperglycemia specifically, whether diabetic or non-diabetic, is felt to lead to oxidative stress. There's some thought that that is part of what causes the diabetic neuropathy, is the chronic hyperglycemia causing chronic changes to the nerves. We don't always know exactly how that is, but I can tell you that there are lots of different things that cause demyelination, including us putting local anesthetic in. But there's inflammatory causes. That's going to be your MS, your Guillain-Barré. There's hypoxic causes, of course. There's viral causes like COVID-19. and there's chemo. And so when you talk to the folks that have been doing a lot of research on COVID brain or brain fog, it's actually the same reason as chemo brain, and it's the fact that the myelin sheaths are being damaged, which slows down actual nerve conduction. There's actually real science, it's not just anecdote. So in summary, you know, regional anesthetics are great in the right patient, in the right circumstance, with the right drug, and quite frankly, the right person holding that needle. There are both relative and absolute contraindications in the ICU. They're slightly different than the relative and absolute contraindications we have in the operating room. And no matter what you think, you need to really thoroughly assess this patient, make a decision if they're a candidate for a regional technique, for which regional technique, what kind of help do you need, and how do you coach your ICU staff to use this as a routine part of their treatment for their patients so that they can make everybody better. And with that, we'll go to questions.
All right, we would love to take some audience questions first. Oh, excellent.
Hey, how you going? Great talk. Thank you so much. My question was just regarding, were there any, when choosing to use regional anesthesia above sort of systemic opioids, were there any demographic factors that might influence that decision, perhaps age or gender or other sort of comorbidities such as substance abuse disorders, things like that? Have you found that using regional anesthesia is, is it effective in patients with substance abuse disorders? And, things like that.
Yeah, thank you for the question. There wasn't a lot of broad demographic studies, but if you kind of look at the whole body of evidence, you can kind of find certain populations in which that'd be more beneficial. If you think about the increased risk of sedatives in the elderly, then tailoring your approach and using being more likely to use a regional anesthetic in an elderly patient, you may be able to avoid some of those sedative medications that can lead to cognitive dysfunction and some of the neurological issues. You also mentioned substance abuse patients. We know that those patients are going to be more resistant to some of the mu opioid effects. So we're having to give increasingly higher doses to get the analgesia, but you really don't get any diminished response in terms of the side effects of those opioids as people develop tolerance to medications. So while there are some smaller case studies and case series talking about using regional and maybe like sickle cell and some of those patients that are on chronic opioids due to their disease condition, there's not really like one paper that kind of looked across demographics and said these people benefit whereas these people don't. And that kind of goes back to what we were both saying, that you have to think about the right technique for the right patient. You have to not just think of the singular injury or singular thing you're trying to treat with this regional anesthetic, but really look at the patient globally and see how this technique can fit into their care.
Thank you.
I think the other thing to consider is that although we are anesthesiologists and we like formal regional blocks, there are other things that can be done that we can contribute, including something as simple as just a field block. The anecdotes not being really evidence, but they are anecdotes. I get the call one night, can you please come see my patient who's having chest pain and see if there's anything you can do? And it's like, what I can do is put some local in her surgical wound and her chest pain went away because her stress went away. She still ended up in the ICU overnight for observation and troponins and the whole rule out. But had we recognized her pain getting out of control earlier, could have put in a block earlier, kept her out of the ICU, made everybody feel much happier. So, we really do have a lot we can offer.
Boris Morovic, D. Ohio State University. I have practical question regarding the put in the block in the night.
I'm
And the
having
patient
trouble hearing you.
comes, can you hear me?
And we are being recorded, so we do want it on the mic.
Sorry. So when patient comes in the middle of the night with the rib fracture, do you put the block immediately, like 2 a.m., versus waiting like a pain team comes in the morning and the original team comes in the morning and plays the epidural?
So, I mean, that's going to go back to having the right provider. When I was at George Washington, which is a level 1 trauma center, we would do these in the emergency room before they even got to the ICU or the floor, whatever their trajectory was. Part of our protocol was to go down in the ER and place these blocks. Now, if this is not a block you're familiar or comfortable with, it may be better for the patient to wait till morning. And so you really have to look at what resources you have, which providers you have, and you should never do anything that's outside of your comfort zone. But if it's something that you see happening frequently, that might be the impetus to start learning some of these blocks and getting more comfortable with them. So you can provide that earlier analgesia, because earlier analgesia is always going to be superior in terms of patient outcomes.
Okay. I mean, you can argue that every anesthesiologist should know how to do epidural.
I would agree with you on that every anesthesiologist should know how to do some of these blocks. But the epidural, while all anesthesiologists can do an epidural, depending on what the patient came in with, you might not be able to sit them up adequately for an epidural. So that's why these paravertebrals and these ESPs are sometimes a better avenue, because you can do those prone or laterally. I mean, I prefer to do them seated, but I've done them both prone and laterally because certain patients couldn't get in that position. And it would be wonderful if everyone in every department was comfortable with all these blocks, but a lot of it just comes with practice and exposure.
Are there actually any evidence or outcome data that doing in the middle of the night versus next day epidural for refracture actually improves the outcome?
So the data that I saw looked more at the regional anesthetic leading to decreased use of systemic opioids, but they didn't really say that the timing of the block itself had a difference in outcome. It was just that the earlier blocks led to decreased systemic opioid consumption.
I mean, I was thinking more in line to prevent intubation. That's the goal of epidural anyway, not just decrease the opioids.
Anecdotally, I can tell you it helps, because that was why we did them in the ER, because even patients with flail segments, we found lower rates of intubation in those patients when they had adequate pain control versus patients that we needed to give heavy sedatives and opioids to because of that pain, and they ended up on the ventilator, and then now you're trying to potentially block an intubated patient, which has its own set of complications, as Dr. Doyle discussed in her portion.
Yeah, the reason is my previous institution, we have surgeon who was really pushing us, and I was the only one in all hospital, and we are busy with just 2 residents. And then I look at the protocol. I think Stanford was like, if they request the epidural for the refracture, they are doing within 24 hours.
Yeah, I mean,
That was their protocol, so it's kind
all
of
logistics as well. If you're the only provider in a hospital at night and you're in the OR, obviously it can't happen. If you're at a large academic center that has several residents, several attendings, CRNAs, having a team go down and do these blocks in kind of real time is a lot more feasible.
Yeah, I don't have problem right now in the Ohio State. Thank you.
The other thing I'll say, especially for hips, it's nice to get the block in early, but there are all sorts of fancy blocks. You know, this patient's not going to be walking until post-op. Good old-fashioned femoral block is perfectly fine. You aren't worried about getting, you know, a muscle-sparing block like you would for something else. I've done a couple of them just on the, you know, patients having EKG changes at the same time. Is that why they fell and broke their hip or not? Let me just get a femoral block in, get the pain part out of there so they don't have to get a bunch of narcotics, and then we can, in the morning, deal with cardiac stuff because they're not acute. So it doesn't matter if it's on the floor or in the ICU for that context.
Hi, great talks, Victor from Mexico City. We've been using epidural morphine, 1 milligram, without any local anesthetic on our floor patients for thoracic or abdominal surgery. Do you have any comments? Because we're now looking into doing this in the ICU for the, you know, the critical care patient.
Yeah, I mean, there's definitely benefits to epidural and intrathecal opiates. There's plenty of studies looking at their use concomitantly with local anesthetic. But I think if there's concern for not using local anesthetic as well, I mean, it's definitely better than not doing it. But if you have the ability to run an infusion or do that injection with local anesthetic as well, you can get a much denser analgesia with it. And a lot of that pain control you get with the epidural and intrathecal opiates is just from spread to the central compartment anyways. So yeah, it's a more direct approach than giving someone IV or oral medicines and hoping some of it absorbs to the point where it's entering the CNS. But again, you have to look at what's happening with your patient and what you think is going to be the best approach for them. I think that the fact that you guys are doing epidural and intrathecal opiates is fantastic, but I don't think it should replace the ability of local anesthetics as well.
Yeah. I will also say if you're going to do epidural or spinal narcotics, you do still want to have the ability to do end-tidal CO2 monitoring on your unit. And so if the patient's on the floor and they can't do that, then that's not a good choice, and you may want to bring them into the ICU or your step-down unit, wherever you have that. We're really blessed. I mean, I am a community county hospital, but we do have the ability to get end-tidal CO2 monitoring anywhere, and that is part of our standard orders for anyone getting any kind of narcotic in a block. And we haven't had any problems since we instituted that. We had a problem once a long time ago, and that's part of why we instituted it. But there's also a cost to this in terms of nursing education. And you do need to factor that into your process. And then who's going to do the nursing education? And so we actually have found that for our group and our site, having us be involved at least periodically in the nursing education and refresher courses is really helpful. For a couple of reasons. One is the social reason, quite frankly, that the fact that they get to know us and we get to know some of them. The nursing staff in the hospital as a whole changes a lot. And so at least if they vaguely remember, oh yeah, we met Dr. Doyle, we met Dr. So-and-so. And then when they're on the floor, they're comfortable coming up to me and asking questions, which is also important. And sometimes challenging the internist or the surgeon if they need to, because we've given them that resource. But also working with your clinical nurse education team about what they're teaching the nurses and how they're teaching the nurses. I will also note that what we put in the epidural may or may not make a difference with where the patient goes baseline. Our pharmacy years ago, because of the hypotension problem, refused to allow a thoracic epidural more than I think it was a 16% concentration. It's like, that doesn't help me with a thoracic epidural. I want concentrated, dense, low volumes. And then they made them all go to the ICU. And we have since changed that because we've changed how we're dosing medications. And it took a long time to teach folks that.
Excellent. Any other questions from anyone in the audience? Great. I just have a couple questions. With regard to our ICU patients, we talked a lot about volume status as far as if they're on renal replacement therapy or really edematous. Do you use their ideal body weight, sort of knowing that their daily body weight is going to swing or potentially change dynamically? Or how do you adjust for their changing weight?
If I'm going to do a dose and I'm looking for calculation for, to minimize the risk of last and whatnot, I'm going to go with their ideal or closer to ideal body weight because the fluid shifts are always so crazy. You can see 2-3 kilos a day. I mean, I think all of us have done that if we're in the ICU very often. If I'm going to make an error, I'm human, I will make an error. I will always go for the side that's going to be more cautious and more conservative, and so I will go with a lower dose.
Yeah, and you always have to think about like these patients in a shock state. They're going to have decreased circulating proteins that are going to be binding these local anesthetics. So the actual free fraction of local anesthetic is going to be higher in these patients. So even if their measured body weight is significantly higher than their ideal body weight, you don't know how much more local anesthetic you're going to have circulating. So when you're thinking about toxic doses and things like local anesthetic systemic toxicity, it's always better to err on the side of caution. If this is a patient you can place a catheter in, you can do your initial dose, you can always give more. Even if you're doing a single shot, you can always repeat the block at some point if you find that it's been efficacious for the patient. But the last thing you want to do is kind of force the issue and be too heavy-handed and not really be understanding kind of the physiologic derangements that are occurring and then cause harm to the patient.
And then with regard to anticoagulation, I work predominantly in a cardiovascular ICU, so most of my patients are anticoagulated. Anticipating that your patient may need a block, do you adjust the anticoagulants that you're using? For example, instead of enoxaparin or Lovenox, would you use more IV heparin that could then be turned off, or do you just sort of stick with your usual and work your block around that?
You know, I've done both. Most of our folks are going to be on Lovenox sub-Q, and it's a matter of, okay, figure out my timing, hold the dose, get the block in, let them give the next dose. So usually we don't have to skip more than one dose. Some of our patients are on every 24 instead of every 12, and then that's usually easy. You just get in there at the 12-hour mark. It does require communication and coordination with both pharmacy and nursing staff to make sure they understand why we're holding the dose and that we are holding the dose, and explaining sometimes to the internists about why we're holding the dose.
And it also depends on what block you're doing. If this patient's on a heparin drip, please do not even think about an epidural until you have a plan. But if you're doing one of a more superficial blocks in a compressible area, and this is actually if you go through the Azra Coags app, for a lot of the superficial blocks, it's business as usual. Because if you're using ultrasound, you can potentially see, like, is there any sort of leakage from a vessel? We talked about the bloody tap. So you'll have ideas that there's potentially some sort of bleeding that's occurring, but it's also something that's highly compressible. There's some blocks that people argue, is this superficial, is this compressible? And once you start getting in that gray area, you always err on the side of it's a deeper block. And in those patients, a lot of the times it says, follow the same guidelines you would for neuraxial, because you're not going to be able to compress a deep vessel. If you're doing a deep plexus block, if you're doing paravertebrals, like some of those patients, if they start bleeding, you are not going to be able to compress that vessel, so that will be uncontrolled bleeding. And those are the patients where you might need to have a more strict plan of what you're going to do anticoagulation-wise.
And then one final question. The majority of today's talk has been geared around trauma or pain related to falls, fractures, things like that. Do you all ever use regional for things that are for example, like a stellate ganglion block for VT storm, or, epidurals for refractory pancreatitis, that sort of thing?
So the stellate ganglion block was the example I was going to bring up. I mean, that's something that's being done more and more in cardiac ICUs. And those are patients, again, who are usually on pretty significant anticoagulation. But also in vascular patients that are having like limb pain due to ischemia. I mean, doing a regional anesthetic on those patients can lead to vasodilation that can help restore blood flow. So while the majority of what we think about are patients coming in as a trauma or coming out of the operating room, there is a whole realm of regional and neuraxial anesthetics that has nothing to do with injury. It's, again, treating symptoms as opposed to treating an actual injury.
Wonderful. Any more questions from anyone? All right. Well,
Thank you, everybody.
thank you. Appreciate it.
Thank you.